Hey there, folks. So we are live once again. Today is Wednesday, the 23rd of October 2024. I got early from the office and we have a lot of MRI scans to report, mostly spinal and brain MRI scans. And I suppose as we go through these scans, I might just stumble upon a few CT scans from the emergency because the emergency never stops. So I have already downloaded our first scan of this morning. Just going to share my screen. Yes, I'm sorry, I have a sore throat because someone, I think at least two people tried to rip my head off a bunch of times in BJJ practice 2 days ago, the day before yesterday, and I got a sore throat because that's what happens when you get your throat crushed by a heavy and skilled jiu-jitsu practitioner. So I got crushed and so did my throat. So this is what we have for today, and this is a lumbar spine MRI scan. I have no coffee here because I have already drank too much coffee for the day. I'm already caffeined up. I don't know if that's a real word, but that's what we are going for. So this is a lumbar spine MRI scan. This patient is a female. She is 59 years of age, and it says she has, let's see what she says. She has lower back pain that goes to her thighs and legs, and she probably has some kind of nerve compression, it says here in her stuff. So as you guys have noticed, this is a major case. There are protrusions and extrusions, mostly extruded discs all over the place. There is a tiny protrusion here at L1, L2. This is 1, 2, 3, 4, and 5. There is no signs of a transitional vertebra. So these are extrusions. This is a protruded disc, and there are clear signs of degenerative disease on L4, L5, L5, S1, and of course L3, L4, mostly on these two segments, but also on this one, that one, and a tiny bit on the first segment of the lumbar spine. Also, we have here arthrosis, moderate arthrosis of the facet joints. We have also hypertrophy and fat substitution, fat infiltration of the muscles, the perivertebral muscles, which tells us this patient is a chronic patient, and this is probably due to chronic denervation of these muscles. There is thickening of the yellow ligaments right there. And let's see if we have vertebral canal or vertebral foramina stenosis. Not so much. Vertebral canal is fine. Let's see the... Oh, yes. I'm sorry. The foramina are kinda reduced on L4, L5, but not as much as we could classify as at least mild stenosis. They are pretty open still, so this is fine. And I think there is some kind of synovitis right there, maybe a bit there, and quite a bit there too. Oh yes, right there. There is fluid accumulation of facet joint effusion right there on all lumbar segments. This tells us this patient has some kind of hypermobility or overload on such facet joints, and this causes an inflammatory response that is also painful. Let's grab a STRIR, a stir sequence, that is edema of the L5-S1 interspinous ligament right there. This is also painful, and we can readily say there is synovitis right there, maybe here, and quite frankly here, there, all the way up to down on this lumbar spine. Also, we can readily see there are inflammatory bone alterations, disease right there. This is bone edema. This is Modic type 1. There is also tiny spots of Modic type 1 all over the place. If we change our view to a T1 weighted image, that those sites go black and also white, which means we also have fat infiltration on such sites. So we have Modic 1 and 2, and maybe Modic 3, which is bone sclerosis. But as this is an acute case, we are going to stick to Modic 1 and 2. So I guess we are done with this one. Let's just grab a template. I have a template right of just this case that fits perfectly this case, and there are marginal osteophytes. There is diffuse Modic 1 and 2 bone degenerative alterations. Yes, let's put a regular tissue here because this is the best sequence to properly evaluate the spine. Conus medullaris is okay. Nerve roots are fine. No measurable stenosis. Just that good old disc herniations. So from L2 to S1 we have extruded discs, and on L1, L2 we have just a protruded disc. So as I report this, if you are enjoying this live stream, don't forget to hit that like button and consider subscribing to the channel. The plan on this channel is to stream 3 times a week, most probably Mondays, Wednesdays, and Fridays, as soon as I can get a hold of my schedule, because it's kind of chaotic still, because this October is chaotic. But I guess next week on I'll be able to stream 3 times a day, most probably in the morning here in Brazil. It's 9:54 as I stream. If not, I might just do it at 2 o'clock in the afternoon. It depends on my routine, but I'm planning on doing this in the morning because it's easier and I'm usually less exhausted. So let's continue. Hit that like button and subscribe so you don't miss the next stream. Just a protruded disc. I'm not showing you the report because there is sensitive information from the patient in the other screen that I'm not sharing. So, and it's written in Portuguese. Just translating it to English as best as I can on the fly. Yes, I'm sleepy as hell today. Gotta get a bit more sleep, a bit more of quality sleep. Every night I'm just sleeping like shit the last few weeks, but I think it's going to get better soon. I hope so. So there is joint effusion all over the facet joints, which is by itself a sign of a painful disease, usually related to hypermobility and overload of the posterior aspect of the spine. This is quite common on such cases such as this, and we are going to describe it as just that. That's just joint effusion on the facet joints. And there is a clear hypertrophy of the perivertebral vessel or muscles. No stenosis, no neural disease of any kind. Just going to summarize this report so we can jump to the next one. And summarizing is very important because we make the referring physician's life easier. So he just looks at the summary of the report and goes usually on his way. He couldn't care less unless there is some major disease described in summary, so he goes back to the actual text of the report. So this isn't the case. This is a very common case of degenerative disease of the lumbar spine, and we are done here. Yep. Let's grab now a cervical spine MRI, clear that, download. This is a 70 years old female patient. It says she has persistent neck pain. Of course, why not? Let's just grab a template, because since this patient has neck pain and is 70 years of age, I suppose she has major disease on her cervical spine, and the images are here. Let's just split the screen. No, this isn't much. I expected much more than this. This isn't that bad. There is a excuse me. There is a increased lordosis of the cervical spine right there. This could be just positional because patient is clearly has a hyperextended neck. This is a malposition. This is to blame the technician. This is not a proper positioning of this patient, although it's all right. We can manage it. We have to report this anyway. There is a anterolisthesis, a slight dislocation of this vertebral body if compared to the next one. This is 2, this is 3, this is 4, and this is 5. So there is a spondylolisthesis or listhesis. There is a slight anterior dislocation of C5 over C6. This is degenerative, probably due to arthrosis of the facet joints right there, and it's major arthrosis, severe arthrosis, which makes sense. We also have arthrosis of the atlantoaxial joints, and of course the atlanto-occipital joints right there. Also the uncovertebral joints right there, and right there, and there are also degenerated. bear signs of typical arthrosis. We have a dehydration, a chronic degenerative dehydration of the discs all over the place. This is quite common. She is 70 years of age, and I can see two tiny protruded discs in C3, C4, C4, C5, just as expected. Nothing major on the vertebral canal. There is no there are no signs of stenosis. And I'm just going to roll the STIR, STIR, the fat saturated T2 weighted image, and there is a bunch of noise. This is quite common because this is a longer sequence and clearly they can't program it right, so the programming is wrong. It gets too noisy, sometimes it gets too shaky, and we lose its point completely because we can't relate to this noise as disease. I'll go to the T1. T1 is here. It's also quite noisy. This is clearly a badly maintained scanner. It's a high field scanner for sure, but there is a huge lot of noise all over the field of view, which means this coil, this scanner, this gradient is all screwed over. This is in need of proper maintenance, and there is facet joint arthrosis. Let's look for neural foramina stenosis. No, nah, fine. And as you guys can see, it was oriented wrongly. The foramina are not properly imaged on this segment right there. It's crooked, it's wrong, but we can readily tell as much as possible that the foramina are fine. So we have spondylosis, tiny protruded discs, major arthrosis of the facet joints, and mild arthrosis of the other joints. No stenosis, no fractures, no tumors, nothing really of greater importance. So that template I told you guys I had, it's fine for this. This is C3, C4. So just go there. Tiny protrusions. C3, C4, C4, C5. Protruded discs, fine. Just adding the facet joints, the uncovertebral, the atlantoaxial, and the atlanto-occipital joints right there. Hello, people. I'm sorry, we go to be. I can't pronounce your name. I'm sorry. Hodem, what's up? Morning, you guys. Welcome to the stream. Degenerative disease, arthrosis of the atlantoaxial and occipito-axial joints, no stenosis. There is some degree of hypertrophy and fat substitution, fat infiltration of the perivertebral muscles because patient is quite obese and she is 70 years of age, so clearly it's understandable. I'm going to report that. Yes, it's being reported. Let's go to the next one. Protruded discs in C3, C4. I'm just summarizing this report so we can go to the next one. Oh, it's atlanto-occipital or occipital. Atlanto, not axial. Sorry. atlanto-occipital joints, which is between C1 and the occipital protuberances, occipital apophysis. Occipital, atlanto-occipital, atlanto-axial. Axial comes from axis, which is the name of C2, and atlanto comes from atlas, which is the name of C1. I know you guys know your anatomy. I'm just mixing stuff up because I'm writing Portuguese and saying it in English as badly as I can. And hypertrophy of the perivertebral muscles. No stenosis. This is fine. Let's just no contrast enhancement, no nothing, just plain old cervical spine. So this is done. We have yet another cervical spine MRI. This is a 51-year-old male. He had contrast enhancement, and this is a lumbar spine. I don't know why they had a contrast enhancement lumbar spine. This doesn't sound like a good thing. It sounds like major disease. No matter, it makes no sense to use contrast enhancement for a degenerative disease of the spine unless you are looking for tumor infection, major infection, and stuff like that. Although in the order, the clinical history says nothing of use, so let's just take an educated guess, because that's what we do. We guess for a living. We are living on hunches here. So they didn't do contrast enhancement. It was a lie. They just said it here to make a fool of ourselves. And yes, no freaking contrast enhancement. Still, this is a quite a regular MRI, lumbar spine MRI, T2 right here. No fat saturation. The spinal fluid is brighter than the fat pad, so it means this is properly weighted. This is a proper weighting, and this is still one. No fat saturation here because fat is also bright and the spinal fluid is dark. So I can say this is bone edema because it's bright on T2 and it's dark on T1, right there and right there. And this small nodule right here on the vertebral end plate, it's a small node. This is a intravertebral herniation, an acute type, because there is edema right around it. So this could be just by itself the cause of excruciating pain on this patient's spine right there. And this isn't surgical in nature. This is just a common physical therapy and medication and rest type of treatment, a conservative type of treatment. No need for surgical intervention for sure. So we have a tiny protrusion right there that I'm considering not to report, but it is indeed a protrusion, so I have to report it. There isn't protrusions upwards from there, but there are some protrusions right there on L4, L5, and also on L5S1. So we have L3, L4. We have that acute small node on L4, L5. And we have yet another protrusion right there on L5S1. So we have a disc herniations on 3 levels, the 3 last levels of the lumbar spine. Excuse me. And just to make sure we are looking at bone edema, we get the fat saturated T2 sequence. This is an STIR sequence and STIR. It is a inversion recovered, a T2 sequence with a inversion recovery additional pulse that saturates the signal from the fat constitution of the structures, both on bone, all over the place. So if it's bright, it's water, and if it's water inside a bone, it's edema, bone edema right there, right there. This is an acute disease. There are tiny spots of acute disease such as that on other end plates like that. This is also painful. And you see, as the sequence is quite longer because you have an additional pulse and it's heavily weighted, this is, you can't really keep the same parameters on a STIR sequence as you do on a regular T2, because you are going to lose signal and gain and produce or not produce too much noise. So it's going to get noisy and distorted and ugly looking. So this isn't a proper sequence, but yet we can tell fairly with fair confidence that this is an acute Schmorl node. This is actual bone edema right there. The nerve roots are fine. The conus medullaris is also fine. Let's see if we have fluid inside the facet joints. Not much. These are vessels, vessels, and vessels. Right there. It's okay. So we have an acute right there, intravertebral herniation right there, which is probably the cause of the patient complaining about lower back pain. Even though we have no clinical history, we are just making a educated guess. Guesswork is 90% of a radiologist work on an everyday basis. So a guesser, a guessing artist more than a medical doctor for sure. Just guessing my way through the day. So let's describe that. I have a template. It's L3, L4, L4, L5, and L5S1 protrusions. There is Modic 1 on the vertebral end plates, especially on L4, L5. And we have a small node on the inferior end plate or plateau of the vertebral body of L4. And let's go. Oh, thank you so much. I have worked with I'm working from home for the last maybe a year, 10 months, maybe 1 year, but I used to work 3 times a week inside the common room at a clinic. We used to do MRI and CT scans, and I used to work side by side with the technicians. We had a great relationship, great guys, great team, and I used to even question the patients myself, and the people that came in with the patients, to actually grab enough clinical history to make a diagnosis. And back then I had to make an effort every I don't know, a few times a day to actually know what I was know to kind of wrap my head around what I was looking at, because I was mostly in oncology and internal medicine back then, so it was really tough to just guess a few of the cases I have to go through. So the technician would help a lot. We would tailor our exams to the best of the necessity of each case, and I used to work my ass off to grab enough clinical history from the patients. Today, as I work from home, and this I'm very far away, thousands of kilometers away from these patients, and these exams have already been done a few days, at least 12 to 24 hours back. I can't really do much, just expect them to send me anything of use, and it's kind of frustrating. It's kind of I don't know, sometimes it quite lets me down a bit, because it's usually impossible to help as much as I expect to help, because I have no information to make a through diagnosis. I can point the diagnosis towards a direction sometimes, but to make a proper diagnosis I need much more than I get almost 100% of times. Yes, and I'm sure you're doing a great job, That's what I expect the technician to help me out with. Yeah, most people just don't care. I can't really. I have almost 16 years of experience. I have worked in dozens of clinics. I have trained a bunch of techs and nurses on the work site, and I have a lot of friends. I had a lot of colleagues, and I can tell you, unless you bitch about it, you usually don't get much from the team. It's unfortunate, but it's real. Most of the times it isn't good. It's just lazy work, lazy deliver. I'm sorry. It's what it is. What it is. Yeah, they don't view patients as their own. You are exactly right. This is just my thoughts. Exactly. I used to say that to the techs that were stubborn and played dumb. I said, you have to treat patients as if you were in their shoes. If this was your own family, just try to make the best as if it was your mother on the scanner, not some random unknown dude that you could care less. Start caring about the patient as your own family, and you are surely going to make a much better job than what you are doing right now, because whatever you're doing, it's crap. I used to have that kind of conversation every now and then with people that were stubborn and dumb, or were just playing dumb to make the least effort on everything. So it sucks because they don't do their job, and I can't do my job properly. Unfortunately, this is the reality of the job. No matter if it's bad, and sad. I have to say it's quite sad sometimes. So we have a acute Schmorl node. This is a very nice diagnosis because it's quite painful, but it's really easy to treat, and patient is satisfied with the diagnosis, and eventually he gets cured, and everyone is happy. I like this kind of situation when people ends up happy, although you give them bad news. So there is mild arthrosis of facet joints and a acute Schmorl node. And this is exactly what I'm writing on the summary of this report. Acute Schmorl node on L4. Just as I guess you guys have guessed. And there is thickening of the yellow ligaments right there. See? Thickening of yellow ligaments. This is degenerative disease. He is 51, so it makes sense. Just going to add that up. Oh, it's already here. It's on the template. So we are done. Did they do contrast enhancement? They say they did, but they didn't. So why just no? Why say and just, I don't know. Makes no sense. Whatever. Sent, done. Let's jump to the next one. Let's see if we have any CT scans from the emergency. Yes, we have 38 ER CT scans already in the queue. So it's 10:23 in the morning and the ER is already going nuts. So let's grab a CT scan of the abdomen. This is a 36-year-old male. He has been throwing up and says his belly hurts on the legs for the last 48 hours, and the doctor says he has some kind of pancreatitis. So his pancreas is hit. Let's grab the images. It's sending over. I don't know if they did enhancement. I suppose they didn't, because why? Why help me out if you can make my life harder? And just do an acute abdomen and don't use contrast enhancement. Let me just guess my way through the diagnosis, as always. Yes, I can tell. Usually I can tell, but it can fool me depending on how the gradient echo T1 with fat saturation sequence is imaged. It depends mostly on the scanner. There are some scanners that look they make a bright blood gradient echo T1s weighting. So we have even though there is no contrast enhancement, it looks like so it can be fooling. In these cases, as I always say, I always recommend technicians to do a pre and a post contrast T1 sequence, identical sequence, at least on one plane. Usually for lumbar spine, I do a sagittal pre and post, and if we have enough time, I'll do a axial pre and post also, but we can go through just the pre and post, so I can be sure that there is contrast enhancement. But usually the most accurate way to tell if there is contrast enhancement in a MRI scan is to trust the technician. If you trust the technician and you look at the post-contrast and it says post-contrast sequence, you trust and you say it is. If you don't trust your team, you just ask, are you sure there is contrast enhancement in this exam? Because I can't tell for sure. And they are supposed to say, oh yes, it is. Oh, I'm sorry, I made a mistake. There is no contrast enhancement. I have gone through that a bunch of times. Sometimes it's impossible to tell. Sometimes they do too little contrast. Sometimes it's too shaky. Sometimes it isn't properly fat saturated. It depends on the case. If we manage to get through a contrast enhanced lumbar spine, I'll be sure to show you, okay? It really isn't common for us to get contrast enhancement because most of my MRI scans aren't from oncology hospitals, thank God. They are usually just outpatient MRIs, just chronic pain MRIs. But I remember yesterday I had a CT scan, not an MRI, of the lumbar spine, non-contrast enhancement, and it was major metastatic disease. They had a destroyed lumbar spine, and I was just thinking to myself back then, oh, thank God this patient could have just get a proper lumbar spine MRI with contrast enhancement. It could be much better than this CT scan right there. So that's a great question, but I have to tell you it's quite impossible sometimes to guess. Just I'm usually, if I have doubts that is contrast enhancement, I'm not going to say it does, because it's really easy to be wrong about it, and you can't really make mistakes such as that, because people like to sue, people enjoy bitching about it, and when they bitch, they make my life a tad harder. So no bitching is best. No, it isn't. It's for musculoskeletal, spine, and usually in, I don't know, I can't really tell from the top of my head, but there are some sequence, I guess, Siemens scanners. They make a gradient echo fat saturated T1 sequence that look like they have contrast enhancement. It's really odd, but as soon as you compare the pre-contrast to the post-contrast phase, you can really tell there is major enhancement. So if you compare both sequences, you can tell where the contrast enhancement is, but just looking at the pre-contrast phase, it's kinda difficult. It can be troubling. Sometimes it can be confusing. I don't recommend. I guess I don't try to guess. I just ask around. I just get in touch with the technician and ask if there is actual contrast enhancement. Also, if you aren't supposed to do contrast enhancement, don't do a pre-contrast phase, because it makes no sense. You're just going to confuse the radiologists trying to figure out why the hell there is a T1 with fat saturation and no proper signs of contrast enhancement, or doubt or confusing signs of contrast enhancement. So if you want to saturate anything in a scan, in an MRI scan, don't do T1 unless someone orders you to. Do PD or T2. A pure T2 and a fat saturated T2 always help. a fat saturated non-enhanced T1 can be just a troublesome sequence to do. Oh, in abdomen, it's another story. We can since we have parenchymatose, solid organs, we can easily say if there is contrast enhancement or not, and if it's enough to be of use, or if they just did it wrongly with too little or badly scheduled acquisitions in those sequences. So because timing is as important as contrast volume or quantity, so you have to do the proper quantity of contrast agent, and you have to scan the patient on the right at the right time. So getting back to this case, this is a abdominal CT scan. We're looking for pancreatitis. So there is clearly a steatotic liver right here. That is fat infiltration. It's moderate because I can readily tell. It's hypoattenuating if compared to the spleen. And I know you guys have seen this. There is fat stranding right there. Settle down. We are getting there. Settle down. 46 compared to 55. So we have moderate liver steatosis, and indeed we have no contrast enhancement in this case. This is just an MPR. Real men do axial. Children need MPR. Just remember that. I'm just doing this because you guys enjoy it. No need to do MPR on the CT scan of the abdomen. I'm a grown man. I'm not a child. So let's just write down the steatosis right there. There is moderate hypoattenuation of the liver parenchyma. Let's continue our scroll from top to bottom. The gallbladder is closed, it's contracted, it's shut because this patient has eaten on the last 8 hours, or he has an acute diffuse hepatitis, which can cause this kind of presentation of the gallbladder. So I'm just going to say that on the report that it's closed, it's shut, it's a shut gallbladder, and clearly we can see that is diffuse enlargement, enlargement and fat stranding, enlargement of the pancreas, especially the body and the tail, with fat stranding of the peripancreatic fat. And I can't see any fluid collections, no fluid collections. In this setting, it should be a, they call it ill-defined fluid collections. We can say anything about necrosis because we would have to have a contrast enhanced phase and compare, and we would need at least 48 to 72 hours of pancreatitis to be able to properly tell if there is any sites of necrosis, which makes a pancreatitis much severe than a regular one. So there is some thickening of the walls of the transverse colon. This is common, a common complication because the colon is right there. There is also some fluid right here, free fluid, and it collects right there on the pelvis. So we have a minor ascites. Is it ascites or ascites? I never remember. I guess it's ascites, which is free fluid inside the peritoneal cavity. Prostate and seminal vesicles are fine. The urinary bladder are fine. No lymph node enlargement, no kidney stones. Kidneys are kind of lobulated, but this could be just a normal variant. The kidneys could be just like that. This is a minor complication right there. See, no need for the NPR. We are grown men. This is a minor complication of a pancreatitis. The tail inflammation reaches the colon, so it hurts. Nothing major, but indeed this patient has acute pancreatitis. Can we tell why this patient has acute pancreatitis? No, we cannot, because most of the times it's caused by alcohol abuse. We have to ask the patient if he has been abusing alcohol, or it could be due to gallbladder stones, but most gallbladder stones are micro stones and they are readily invisible on CT scans. So if you are looking for gallbladder disease stones in a CT scan, no matter if it's enhanced or non-enhanced, you are wrong. Don't do it, because you won't get much in about 70% of the cases. So we have steatosis. We can see this patient is obese, and he has an complicated acute pancreatitis. So let's report that and be on our way, because we have another bunch of CT scans to deliver to the ER. Kidneys, lobulated contours, and we have some small mild ascites or ascites. I don't know. You guys leave it in the comments below. How should I pronounce it? Because I can't really remember. Did you guys see the appendix? I did see the appendix. It's a good practice to always look for the appendix. The appendix is right here. It's vestigial in nature. It's hypoplastic. It's right there still. That's the appendix, the cecal appendix, the vermiformis appendix. Right there. The appendix is there, and we are ready to go. So I'm just going to grab a Balthazar classification right here, so we can classify this pancreatitis. So we have a enlarged pancreas with diffuse peripancreatic inflammation without a fluid collection. So it's a Balthazar C classification, just for fun. It's really not that important. But I like to say that on the report because reasons. No need to memorize those classifications, just know them and study them. And we are done. Let's go to the next one. We have here a left ankle from the ER. 15 years of age, left ankle, looking for a fracture. What's the best exam for fractures? X-rays. If you're unsure about a fracture on an X-ray, do an MRI. No need to scan on a CT scanner unless you are looking at a complex fracture and you need a 3D reconstruction, a multiplanar, a surface reconstruction to plan a surgery. Really, CT scans are much better than X-rays. Well done X-rays for bone fractures. But who am I to tell that to people? They just keep ordering stupid and useless scans of bones for fractures. So this is an ankle, sagittal MPR, and of course we need MPR for bones because we need two projections at least to be sure, excuse me, there isn't an acute fracture or dislocation or whatever on a joint. This isn't true about brain, chest, abdominal, and pelvic scans, but bone scans are another animal altogether. So I'm just rolling up and down. If you guys see anything, just shout on the chat. I don't. I think bones are fine. Let's just scan on the sagittal view. This is a sagittal multiplanar reconstruction, a sagittal projection built from this one. This is not a bone recon. I couldn't care less. It's not needed. It's a volumetric isotropic acquisition. It's more than enough. It's a great resolution scanner. Nice, new, well calibrated, well maintained scanner. Can't complain. About the scanner, I can't complain. And I am complaining about the purpose, the need for this exam. It isn't needed. It's just yet another useless scan from the emergency. That is, of course, densification, fat stranding of the subcutaneous tissue right there. They are probably looking for a tip of the fibula fracture, which would be a avulsion fracture, which is surgical in nature, but we can only tell there is a edema right there related to a torsion of the ankle, a ankle torsion, a inversion type torsion of the foot. So there isn't much here to report, just a plain old, almost normal ankle. I like the sound of that ankle. What's that? It's an ankle. Ankle. It's funny. I need coffee. Guess I'll grab some coffee. Need coffee. Soft tissue on the lateral aspect, anterolateral aspect of the ankle is edematous. It's increased in thickness and diffusely densified. So this is edema. This is it. No fractures, just edema. Nothing major. Still, this is just a 15-year-old patient. It wasn't supposed to be major disease anyways. So let's grab another. We are already 1 hour in the stream. Let's see. Brain CT scan. Why not? Brain CT scan. Let's grab a brain. 58-year-old female, and it's a follow-up exam of a huge stroke. They say here it was huge, extensive stroke. I'm downloading both today's exam and the exam from the 17th of October, which is almost 5 days ago. So we are going to see both, and we are going to tell how bad this patient is as of today. So let's go. It's downloading. CT scans are usually much bigger, much larger files than MRI scans, especially because they do send us too much images. So they did a malpositioned scan right there. See, this is the 23rd. This is today's scan. They did a very malposition, so they made a recon that corrects the patient positioning, but introduces a lot of positioning artifacts. But we can live with that. I guess it's passable. There are a bunch of calcifications. I know there is diffuse ischemic stroke right there. I know. Settle down. Don't scream at me. I've seen it. There is also major white matter disease, microangiopathy, severe microvascular brain disease. There are a bunch of small lacunar strokes right there, which is quite common for such case. Some calcifications. This is dystrophic. This is residual calcification. Just measure that. I guess it's 0.5, 0.4, almost. So a bunch of tiny calcifications. Atherosclerosis, of course. No. Hydrocephalus. Remember, this is a 58, almost 60-year-old patient. Okie. Let's grab the exam from last time. Last time's exam, it was much better positioned than this one. See, this is the acute stroke. This is also the acute stroke, but not so acute. So it starts to be less dense, more hypoattenuating, and less ill-defined. So this is the usual follow-up features. These are the usual follow-up features. Also, we have effacement of the sulci, and these effacements tend to reduce themselves after a few days. It's still not reduced, and we could see here a bunch of signs of acute hemorrhagic transformation of a severe ischemic stroke, just like this, but we don't, which means there is no acute hemorrhagic transformation. And I can't properly image this. Let me just window this. It's tough. I don't know. Someone messed around with this recon, I guess. It's okay. Let's compare brain swelling between these two scanners. These two scans. No, sulci are quite the same, maybe a bit reduced in this case, but not as much as enough for us to report it as different. And there is a tiny decrease in ventricular size, which also points us to some brain edema. Nothing major. There is a lot of space left for the brain to continue swelling, but this is already 5 days after this one, so it isn't going to be like that. It is going to be getting better the next days on. So we have an acute middle cerebral artery territory ischemic stroke on the left, major, no signs of acute hemorrhage. We also have major microvascular disease of the brain white matter. We have no hydrocephalus. We have atherosclerosis of the carotid vessels. Also, the vertebrobasilar circulation is also atherosclerotic, and we have a bunch of small dystrophic or residual calcifications all over the place. And just to finish, we have a few lacunar old strokes on the cerebral basal ganglia on the left. This is mostly caudate nucleus. So let's report that because we don't have much time. I usually report this kind of exams in a couple of minutes, so but since I'm streaming, it could take much more, as you guys have noticed. So this is why I always say hit that like button, subscribe to the channel, comment, share this video, because it's tiring to stream and it doesn't make my work easier. It just makes it much more fun to work. So just going to describe now the ischemic stroke. Basal ganglia affected, not much. Frontal, parietal, and temporal lobe. Yep, that is it. This is it. On the left. It's on the left, just to be sure. Mild hydrocephalus, which is normal at this age group. Just summarizing the scan, and I'll leave a footnote saying it's as it's supposed to be, nothing major, comparing it to the last scan. A follow-up note. Oh, I just remembered, I have to say there are a bunch of calcifications all over the place. Yes. This is usually due to neurocercosis or any other type of infectious disease that goes through the blood-brain barrier and takes over the brain. Eventually gets cured and turns itself into calcifications. So let's go to the next one. The next one is a chest CT scan or not. Let's grab a chest CT scan from the queue. This is a 50-year-old male. It says he has suffered trauma to the chest on the right. He fell off his bike and they are looking for fractured ribs. So this is major trauma. It should be done with contrast enhancement, but usually it isn't, which is a mistake. So I'm not going to rush. I'm going to download the images. There are 1050 images on this exam, and it should be, as my experience tells me, it will not be contrast enhanced, unfortunately, but let's hope for the best. And this is a great time for you guys to hit the like button and subscribe. Hit the subscribe button and help me grow my channel. We are trying to get to the 100 subscriber mark. I've been working on this for almost 6 months, and I can't really tell, it's encouraging to look at Google Analytics, YouTube Analytics about this channel. It just doesn't move much. I suppose as soon as I start streaming 3 times a week on the same schedule as I'm trying to do since last week, I guess, it's going to ramp up and grow, I suppose, but I always count on you guys helping out with likes and shares and all that good YouTube stuff. So this is a very muscular patient. He is 50 and he is very muscular, pretty thin fat pad on the subcutaneous tissue and a lot of muscle, and he bikes. So let's look for emphysema. No emphysema, but there is quite some edema of the superficial tissue. So there is a tiny effusion, pleural effusion on the right. He has gone through bariatric surgery right there. Bariatric surgery, gastric bypass. They scanned the abdomen, go figure why, but no, they didn't do contrast enhancement, of course, because why help the radiologist if you can just make my life shittier? Just Leave me to guess, because I'm a guesser. My profession is guessworking on scans. That's what I do. I take educated guesses. So there really isn't much of an effusion, a pleural effusion, just a pleural thickening on the right base of the chest, and maybe, just maybe, a bit of the same on the left, right there, maybe, might be. The lung parenchyma seems fine. Seems okie dokie. Tiny laminar atelectasis on the base on the right. So okie dokie. No major lung contusion, no major consolidation, no signs of ground glass opacities. I know, I'm going to look for fractures. Settle down. It's going to be just now. I'm just going through the easy stuff first, so we can put that aside and look for fractures. This is calcifications on the aorta, calcification on the coronary. The heart is normally sized. The esophagus doesn't seem to be thickened. There aren't enlarged lymph nodes anywhere I can tell, nor masses. Thyroid seems small. Now I'm going to do a MPR, because MPRs are needed for bone, as you guys know. So bone needs MPR. So there is spondyloarthrosis of the dorsal spine, and we are going to look for fractures, and we are going to look in at this side first. Let's just put it here. I'm going to grab a sagittal for later, and here we are. Right side from the 12 rib upwards. Let's see if we can see in fracture. Are there in fractures? Did you see fractures? I didn't see fractures yet. No fractures. No fractures, just arthrosis. Nah, no fractures. Let's look at the anterior. Oh, right there, fracture. Yes, there is a fracture. Usually it isn't just one, usually it's more than one. So one fracture. In this case, there is just one fracture. So let's see if there are spinal fractures. There could be transverse process fractures, or spinal process fractures. This is not a fracture. Transverse process fractures, no fractures. No fractures. No. Agora we have to know which rib is that. So this is 1, this is 2, and 3, and 4, and 5. So the 5th rib on the right is fractured, and the thickening of the pleural leaflets on the same side. So let's just, because we have to, let's look for fractures on the left. It says the patient had a trauma on the right side, so we're not supposed to find fractures on the left, but it won't be the first time they got it wrong. And he has fractures on both sides of his chest. Not this case. There is no fracture here. Yep. Let's just confirm that fracture on the sagittal view. So you guys look for yourselves and just don't trust me. See, spondyloarthrosis. Is the sternum fractured? No. Is the right collarbone clavicle fractures? I couldn't be sure because it wasn't imaged completely, but the part we can see isn't fractured. Let's see if they're all right there. This is an acute fracture right there. So indeed, 5, 4, 3, 2, and 1. So it's the fifth rib indeed. Fifth rib on the right is fractured. So let's report it and be on our way. Just spondylosis, spondyloarthrosis of the dorsal spine. I'm sorry. As I said at the beginning of the stream, I have had my throat crushed by BJJ graduates, BJJ collar belts, as they say. They were mean to me. They tried to rip my head off my neck, and they almost did it. It was fun. I'm going to try it out today yet another time because I want to rip people's heads off their necks in a figure of speech way, of course. Jiu-jitsu is fun. So just atelectasis, a tiny laminar atelectasis on the base of the right lung and the fracture. Fifth rib on the right. Mild atherosclerosis of the aorta. And mild atherosclerosis of the coronary vessels. Can't miss that. Just summarize it. And we are down here. We are down. Right there, down. Fine, just fine. So guys, it's already 11:09 in the morning this Wednesday. Thank you so much for tuning in. We are already streaming for almost 1 hour and a half. I'm quite tired. I need some coffee. I'm going to take a break. And I hope to see you guys in the next stream. Thank you so much. See you soon. So long.